So next, I would like to invite Dr. Carolyn Burns as our keynote speaker for today's session. Dr. Burns has been the medical director and the chief of pathology at the Jewish Hospital Healthcare System Department of Pathology in Louisville, Kentucky. She is the current president of the Society for the Advancement of Patient Blood Management, and she is a passionate advocate for patient blood management and has published many articles and textbooks on this topic. And she's a prolific speaker, and she's sought for speaking at many PBM societies and conferences, and we are so lucky to have her here. So she's going to give the keynote address, which is Patient Blood Management and Bloodless Medicine, State of Science and State of Art. So Dr. Burns, all yours.
Thank you. Thanks, Gagan. Really appreciate it. And thanks to Dr. Rafaya, Dr. Bloomberg, who gave such excellent talks and have really kind of teed up a whole lot of what I'm going to be mentioning today. So let me go ahead and share my screen, pull my slides up, and we will jump right in. Wonderful. So thanks again very much. It's a real honor to be here as the keynote in this SABM BMSS session. This is a very special meeting for us and a very special thing that we do through our Memorandum of Understanding with the Bloodless Medicine and Surgical Society. So I would be remiss if I didn't thank each and every one of those folks that were on that planning committee and are part of BMSS for making this happen every year. And I was not able to attend the last 2 days due to other commitments, but I've been watching the social media and the things on LinkedIn and WhatsApp coming through, and it sounds like it's just been fabulous, and attendance has been wonderful. So we're getting the message out, right? So when I started to talk with Nat and the rest of the committee about this particular keynote, I was having these thoughts in my head recently about how medicine has changed over the course of my 30 some years in practice and ultimately in consulting. And I was really starting to think about where are we with the state of the science, as we would call it? Where are we state of the art? How do we, in a sense, for those Star Wars fans, how do we Vulcan mind meld these Star Trekky kind of thing? How do we do that? Are we doing it well today, or are we not? And how does patient blood management, comprehensive patient blood management, and bloodless medicine as a part of that, how does that fit with where we are currently? So that's where I'm going to go today. A little bit of philosophy and a little bit of science to, again, kind of round out what our previous two speakers have discussed. This is my obligatory disclosure. I will not be discussing any of these entities. Important at the bottom is my email. Always feel free to get a hold of me to further discussion, ask questions. If you'd like some PDFs of some of the articles that I'm sharing, please do so. So again, I'm going to define what I see and what, the Webster's Dictionary would call state of the science and state of the art, and kind of discuss those concepts of then where we are with our evidence-based care versus what I'm going to call narrative-based care. And I'm going to illustrate then, I hope, to you how I see PBM and bloodless medicine and surgery truly reflect these principles and practices. So some of you know I'm big on words. I used this slide at the annual meeting when I was presenting the global definition. And it comes from being deeply rooted in a home with an English teacher, as many of you know. And my mother used to tell me, you need to choose your words. Words are very important. They represent you, your character, and the concepts that you're trying to project and potentially have people embrace. And I think it's very important when we use our words then, and I love this particular quote by John Birmingham, who was a British author, words matter and the right words matter most of all. So if we consider those words in terms of state of the science, if you go to Webster's or you go on Google, we can see that state of the science means this is that current condition or our current position where we have a system base of our knowledge that we've garnered through our physical world, through our expectation. We try to do unbiased studies, whether they're observational, cohort, retrospective, or randomized controlled trials. That's our state of the science. And we've seen the state of the science in terms of transfusion, optimal blood use, and bloodless medicine and surgery, patient blood management, all coming really into the forefront since about 1999. And Neil mentioned that very landmark study of Hebert and his group out of Canada, the first randomized control trial ever done in the arena of transfusion medicine. So that's our state of the science. This is evidence-based, right? This is where we go and we read the literature and we try to adapt that literature to our own practice. Now, if you talk about state of the art, what does that mean? And how does that fit into our medical practices? Well, state of the art, I think of, I would imagine you do too, I think of technology, right? I think that's the most recent, the latest and greatest, the highest stage of development, right? I can tell you, I just got a brand new, let's pretend I just got a brand new TV, and it is state of the art. It's got all the whistles and buzzers. So these are the technologies that we have our fingertips in patient blood management and bloodless medicine and surgery, whether those are minimally invasive procedures, robotics, our use of new topical hemostats, or other pharmaceuticals, cell salvage equipment. All of these technologies are state of the art. So we have as well with state of the art, even though it uses the word art, it still in a way is science, because we look at that by definition as technology. So let's go even simpler. Let's kick ourselves back to the art of medicine. And we all, when we're healthcare providers, know that we are here to practice good science, good evidence-based medicine. But have we lost the true art? And art is that expression, I love these words, of application and appreciation, especially through our senses. So this brings that patient-centered expression, application, appreciation, where we're using our senses predominantly, right? We're using sight, touch, and hearing. We see our patients, we look at them, we listen to them, we examine them. We sometimes, absolutely, yes, we can smell them. And back in the olden days, I remember when pathologists used to dip their fingers in urine and taste it to check for sugar, diabetes. Mercifully, we don't do that anymore. But what we're doing is we're using our senses. And this is the basis of the art of medicine. So if you look at the art of medicine defined, again, words, this means we're becoming human again in our approach. We're using what we'll call narrative-based medicine. And that involves us listening and looking at our patients. And what I loved about this definition is it says we're understanding their perspective without any judgment or being too quick to respond. I know many of you probably do like I do. When I was seeing patients, I would go in and I'm hoping I'm listening to them, but I'm sure what was going on in my brain was sometime I was listening to what they were saying, but I'm already clicking the top 3 in my differential diagnosis, right? And I'm already making, in a sense, a little judgment about what they have. What is their disease and what am I going to do about it? So we need to step back and allow that narrative base, our senses, to be really used to the fullest so we provide patient-centered care. So this is where PBM and bloodless medicine and surgery fit. It's the perfect example of patient-centered, patient-oriented, narrative-based care, right? To actually practice PBM and also those bloodless medicine and surgical techniques, tactics, whatever we want to call those. It demands that we combine our state of the science, our state of the art technologies, and provide the narrative-based care. So it's a perfect example of what we need globally. And that brings us then to the global definition, right? And many of you have already seen this. We discussed it at the annual meeting. It's also published officially in the September themed issue of Anesthesia Analgesia. But notice the words. Yes, we are using a systematic evidence base. Yes, we want the latest and greatest in the science. We have to come full circle with where the literature speaks. We cannot turn a blind eye to that science. But notice where we're talking a lot about then applying that science to the narrative so we provide patient-centered care, improved patient outcomes, preservation of the patient's own blood. And this means patient safety and patient empowerment. They're becoming part of our team. And we all know that in patient blood management, as Savim describes it, we have our 4 pillars, right? We have diagnosis and management of anemia, optimizing hemostasis, minimizing bleeding and blood loss, interdisciplinary, multidisciplinary conservation techniques to preserve the patient's own blood. And the fourth leg of that stool is patient decision-making, right? We can't have the three legs do what they need to do without that fourth. So I love the fact that the authors, the group that worked on this definition, they really focused on these words and forced us once again to come back a little bit more into the art of medicine. Now, we can all say, we know we have barriers to this. We talked about this as well. Professor Hoffman brought this up at the annual meeting. Why do we have these barriers for implementation of PBM around the globe? And yes, it is very difficult. As you can see in this quote by Dr. Roberts, weaning us off of our love affair with blood is no easy task. And that means that it shows us that we are complacent in our way we feel we use blood. Our dogma is very tenacious. It's very hard for us to give it up, right? We've done it for years and years and years. So it's what we do, isn't it? We have a lack of knowledge and education surrounding not just transfusion, but all of the additional aspects of comprehensive patient blood management. And we, as healthcare providers that are here today in this virtual room, we need to be pushing this message, take that science and move that forward. We have to use that to try to combat this lack of willingness to change. And we have that. We dig our heels in, and we have to start opening our eyes, opening our ears, and coming back to that art. Now, I will be fair that I want to say too, that PBM is not an easy thing within your institutions. Those of you that do it and do it well, know you've probably had a long journey with infrastructure. This is why SABM is a multidisciplinary, multi-professional group, right? We know it takes doctors, it takes nurses, it takes laboratory professionals, it takes pharmacy, it takes administrators, it takes perfusionists, it takes all of us to make this work. And those of you that do it well have that infrastructure. Those of us that perhaps are on the struggle bus a bit, we need to work on this. And it's very important. And I will say that means we have to challenge ourselves to change. So if we look into some of that literature, that state of the science, and already Dr. Rafai, Dr. Bloomberg had talked about these things. And here's another visual that shows us, and these are things we can share with our colleagues who probably or maybe are not quite there yet to start getting into patient blood management. Maybe they don't understand those concepts quite yet. They haven't read the science. Well, this is a beautiful visual from Dr. Spahns, and thank you, Dr. Spahn, for allowing me to use this. And I really think it drives home that message that when we limit or eliminate the need for red cell transfusions in particular, but we'll see it mirrored in the yellow stuff. Yes, we reduce the number of transfusions. That's good. That's great. We want to do that. But where the rubber hits the road is we're removing those complications. We reduce acute renal failure. We reduce the infection rates that Neil just spoke of. We reduce those thromboembolic phenomena, which, by the way, our University of Rochester folks have published on. We reduce mortality, and we reduce the length of stay. So all of these things go to improving our patients' outcomes. If you want to look at it another way, you can share some of these citations with your colleagues as well, or if you haven't read them, please do. It really speaks to the fact that liberal use of transfusion is not necessarily providing better outcomes for our patients. And in fact, we're very often doing that harm. And this is in a dose-dependent way. And Neil brought that up, unit for unit for unit. And we see it in surgical patients as well as in medical patients. And if you look at just the surgical arena, you can see for every single unit that we transfuse, we increase wound infections, length of stay, ventilator dependence, pneumonia, thromboembolic events such as MI, we heard that just a few minutes ago, stroke, DVT, PE, and increased mortality, unit for unit. Serious infections in our medical patients as well. And just a recent article in Critical Care that I got just probably 2 weeks ago speaks to an increase in 1-year mortality of those who survived their ICU stay when they are transfused. And Dr. Rafai just beautifully represented their paper where they showed that RBC transfusions are not improving O2 delivery and or tissue perfusion. So these outcomes, these matter. In the themed issue of anesthesia analgesia, 2 additional studies. Look at the top one by Trentino. These are our Western Australian colleagues, that even a single unit causes more hospital-acquired infections and increased length of stay and readmissions. Readmissions is a serious issue for most of us in our hospitals. And I think I would say most of us, we don't want to see our patients bounce back. I want to see patients I've seen maybe at the grocery store or at church or out walking their dog. I don't want to see them back in the hospital. We want to think our patients are leading, healthy, quality lives. For each unit, we increase this. And then, of course, in the CV surgery arena, we're seeing that increased odds, again, of post-operative infections. So are we doing harm when we receive these? And what I think is very important is if you look at that ANA issue, Dr. Gooby has the forward at the beginning, her editorial. And she mentions these articles and says it really gets us going down even a different paradigm. I think we've all been bandying about this notion of why give 2 when 1 will do? Well, as she very nicely states, it begs the question of why give 1 when none will do. So let's think about that. If we have otherwise stable patients, can't we be intervening without transfusion at all? If you want to see some literature, mirror image of red cells, let's talk about the yellow stuff. Platelets, notice, increased nosocomial infections, no clear benefits even in patients with intracranial hemorrhage. Actually increases those outcomes and mortality in patients when we treat them, even if they're on antiplatelet medications. When they get peri-procedural prophylactic platelets, increased bleeding, increased admission to the ICU, and prophylactic pre-procedure platelets increase that risk of thrombosis and mortality. And that is our Rochester colleagues' literature. That's their state of science. Plasma. Plasma, for those of you that know me, you know I am a bona fide, self-proclaimed plasma phobe. I don't think that there's very often any reason to be using plasma. Very, very few circumstances. I think it's the most misunderstood and misused product that we have. But notice what we're seeing now in this literature. Increased infections, increased multi-organ failure, increased adult respiratory distress syndrome, increased morbidity in our oncology patients, increased odds for red cell transfusions as a surrogate of bleeding. We're actually increasing bleeding when we provide plasma. And then worse outcomes in terms of both mortality and neurocognitive outcomes in patients with traumatic brain injury. So we're seeing the literature, the state of the science with the yellow stuff, catching up with where we are with the state of the science with reds. And all of these things definitely could be due to those immunomodulatory effects, storage effects, just like have been presented previously. So if you haven't seen the study, you may have earlier in this past couple of days, but it's worth reiterating if you have seen it. I think this is a very important study because we've taken a step back from just randomized controlled trials of a restrictive hemoglobin threshold versus another. We've got tons of RCTs with those in a variety of patient populations in both neonatal, pediatric, and adult patients. So enough, let's dispense with those. But tell me about these non-transfusible versus transfusible patients. And in this particular systematic review and meta-analysis, non-transfusible, by the way, is not just those that are non-transfusible because of their religious faith. It also could be non-transfusible because you have a patient with an unusual blood type or who's alloimmunized to a degree but that you can't procure blood for them. It's not available. So what do we do with non-transfusible patients? We go down the road of bloodless medicine and surgery. We think outside the box and we figure out a host of ways to support them. And we know they will do fine. And this study actually showed that. Those that were non-transfusible versus those that ultimately could be and would accept transfusion had no increase in mortality, They had lower length of stay in the ICU and actually trends toward decreased infections, acute myocardial infarction, reoperations, and lower hospital costs. Now we're going to get the elephant out the room in terms of cost, because all of us as clinicians, we hate to talk cost, but we have to realize we need to be fiscally responsible. And any of us that are in tight resource areas, whether we're low, middle, or high resource countries, we all have our issues with those resources and how we're going to spend our dollars. So if we can lower those costs and provide better care, that's being fiscally responsible, and we can funnel those dollars back into care within our communities. So it's really a win-win. Now, I would imagine that Dr. Frank presented his latest data. This as well is published in the themed journal of ANA. And I think it drives home the message again, and Neil brought this up too, that bloodless medicine patients do as well, if not better. I can tell you in my own institution, I didn't publish, but anecdotally, our bloodless medicine patients, our patient blood management patients did as well, if not better, than those that received transfusions. And when we limited those transfusions, we found that as well. So here's Dr. Franks and the Hopkins group, where they had their bloodless medicine patients compared to those of standard care. Morbidity and mortality were comparable. So we're not doing harm by not transfusing, right? We're taking our state of the science and applying it so we limit or eliminate that need for that transfusion. And actually there were trends toward lower M&M in the patients that were bloodless care. And once again, they showed some lower hospital costs. So they're saving money that they can funnel back in. So that's the economics of the issue. And that's where we need to be taking those dollars and applying them to where we need for our communities. So Steve was very kind to allow me to share his chart. You've seen it. It's worth looking at again. We've got blue is for bloodless. We've red for standard care. And notice the differences in terms of the percentage of patients and that composite morbidity and mortality. One of the best things I found in this particular article is the pull quote from the discussion. And again, it drives home the message. We're using the state of science. We're using state-of-the-art technologies, interventions, but we're bringing back the narrative of care. We're bringing back the patient decision-making, patient autonomy, where medical providers respect and honor patients' wishes to receive or not receive specific therapies. We should be considering this in all of our patients, which without regard to what kind of treatments we're proposing. We give our patients the choice of their chemotherapy, the choice of their surgery, the choice of blood, no blood, or other items. So we bring that narrative care back. I'll also share with you, this is an article by Isbister et al. This is the Australian group, and they published their article in the themed journal. And if you want something to really drive home the message of narrative care, your personal art of your medical care, read this article. It really focuses on the person that we're treating and how we're going to focus with patient blood management by evaluating them, managing any of those blood abnormalities, whether that's anemia or coagulation abnormalities. We're going to try to minimize or avoid allogeneic transfusion whenever possible. And we do this in the backdrop of that patient-centered education. And I will say also educating their families or other caregivers that they have, and making this the team effort to provide them both continuity of their care, inpatient as well as outpatient. So a wonderful publication that really draws us back into our art of medicine. So we get back then to this whole idea of, yes, we want the state of the science, we want the state of the art, we want our narrative-based care to ring out and bring everyone around the globe to understand this urgency for patient blood management. And I think the WHO policy brief that came out 2021 really states this, that we have an epidemic of anemia with over 1 billion people affected worldwide. And let me put that in a little bit different statistic. If you look at some of the other statistics that are done, it really speaks to the fact that probably within each of our own regions where we practice, probably 1 out of every 3 to 4 people are suffering from anemia. So that means if I look at my two kitty corner neighbors in my neighborhood, the two couples that live on either side of me, that means one out of them has anemia to some degree. And that anemia, by the way, read an interesting article just the other day that put it in this perspective. The disability or the decreased quality of life associated with anemia is greater over the years than the combined disability or decreased quality of life from those that suffer combined diabetes, cardiovascular disease, and asthma. Wow. Anemia has lower quality of life over years compared to all of those diseases combined. And Dr. Rafai mentioned that right out of the gate, how this affects our patients. The most common etiology, yes, is a simple nutritional deficiency, right? That many of us can easily correct. Maybe others not so easy due to resources, but we have to look at this nutritional deficiency. We also, as the policy brief points out, we have roughly 600 million people that have some form of congenital or acquired bleeding disorder, which causes them to have acute and or chronic blood loss. And that is going to contribute to that anemia burden. So we have to, again, take our state of the science, our state of the art, our narrative-based art of medicine. We have to start saying to ourselves, anemia is bad by itself. Coagulopathies are bad in and of themselves. Transfusions are bad. So now we put them all together, and what do we have? The great trifecta of not goodness. So let's get back to this urgent need for PBM and our bloodless medicine and surgical approaches to our patients. And this is what will compel us to move our own practices forward. It will challenge us to change, help our colleagues change, and move forward with this PBM as the global standard of care. And when we take that state of the science, state of the art, and our narrative-based, our art of medicine, it really gets us back to this quote by Dr. Peabody, way back from 1927. We can treat a disease. We can go check, 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 check. Think all you want about that disease. But when you personalize that care, you patient focus that care, the care of the patient is personal. And I think that's where PBM fits. I think it exemplifies it. It is everything we do in patient blood management is that. It's making it completely personal. So thank you very much. I really appreciate the opportunity to be with you, and I'm very honored to be a part of this session and to be a member of BMSS as well. So we'll await the questions, answers, and discussions. Thank you very much.